This program is brought to you by Emory University.
Good morning, everyone. Welcome to another exciting talk for Emory Heart and Vascular Grand Rounds. We have one of our own, Dr. Bryan Wells, who is an associate professor here at Emory. Dr. Wells is also the director of vascular medicine and really started the FMD SCAD program here at Emory. He's been very active in the international and national SCAD community. We also have a registry for SCAD here at Emory. He does venous ablations and he's also board certified in vascular medicine. So just a really nice specialty that complements cardiology. And today he's going to talk to us about vascular medicine at Emory and what's been happening. I'll turn it over to you, Bryan.
Thank you, Pooja, and good morning, everybody. And it's nice to see everybody virtually and spend some time with you this morning and go over vascular medicine and what that is for Emory and give you a little bit of an overview of what we do, some of the cases that we're seeing in clinic, and hopefully share with you some of this information and teach you a little bit too about what we're seeing clinically. And like Pooja said, some of the research interests we have, particularly with FMD and SCAD, and Pooja is actually a part of that SCAD team we have here at Emory as well. So thankful for all the collaboration that we've had since we've started this vascular medicine program 8 years ago, and looking forward to future collaboration. And each and every one of you, it's always an honor and privilege to work with you on a daily basis here at Emory. So with that, we'll dive right in. So this will be a presentation of 4 clinical cases that, again, will give you a nice overview of the flavor of patients we're seeing within vascular medicine here at Emory and some of the science behind what we're doing. So the objectives are going to be to identify under-recognized vascular disorders, know the differential diagnosis for non-atherosclerotic vascular diseases, understand the evaluation and treatment of patients with known or suspected FMD SCAD and other related arteriopathies. So case 1, 42-year-old woman with no past medical history presents with chest pain for 2 to 3 days. She seeks medical attention where abnormal blood tests, in this case a troponin, prompt urgent heart catheterization. She denied any significant family history of heart disease, smoking history, oral contraceptives, so no traditional risk factors. In addition, her pregnancy test was negative. Because of her elevated troponin, she was taken to the cath lab, and here's her coronary angiogram here. And to orient you, this is the left coronary artery, the left main up here, and the LAD. And what you'll see in the left circumflex, heading down towards the mid segment, you see a smooth narrowing, a tubular stenosis, and some reconstitution of flow distally. The other thing I'll point out is that this LAD isn't completely normal. It appears to be fairly tortuous. So what you're seeing here, the cause of this stenosis likely is not atherosclerosis. Again, this patient was young to middle-aged, did not have any traditional risk factors, and this smooth narrowing is a type 2A SCAD. So it is more likely that it's an intramural hematoma. You don't see the classic flap that sometimes we look for, but type 2 SCADs are the most common that we see in clinical practice. And I'll also point out that with this tortuosity of the LAD, again, that's not normal. That's something that has been overlooked in the past, where we, when we're evaluating young women with chest pain, and we may call them tortuous vessels or small vessels. And in fact, what we've probably been seeing all along is that this is a coronary manifestation of fibromuscular dysplasia. So the patient was doing well with medical therapy, but did have some recurrent chest pain concerning for propagation of her SCAD 5 days later. And that's not entirely uncommon for that to happen within 3 to 5 days. But as you can see, there's a little more reconstitution of flow, and that's typical for the natural history of SCAD with medical management. These lesions will heal on their own. So she did not require intervention. She was not in cardiogenic shock or having persistent chest pain or elevated troponins. So this heart catheterization was actually reassuring. And again, you can appreciate the marked tortuosity of the coronaries here. She was doing well and was discharged on appropriate medical therapy, and we'll talk about that in a few minutes. And unfortunately, approximately 8 months later, she had chest pain that was typical for her SCAD event that she had had 8 months prior. And she went to the cath lab again, and you won't see it in this view, but she actually did have recurrent SCAD in a small LAD branch that did not require any revascularization. But the point here is that if you look at her circumflex, that same area where she had the SCAD 8 months ago, it's completely healed. And this is typical for SCAD. We prefer medical therapy and conservative management, and this is very, very reassuring. It's unfortunate that she had lost a small branch vessel of her LAD, but this circumflex is completely patent 8 months later, as you would expect. And in fact, we did do screening for fibromuscular dysplasia, and she did have a FMD of other vascular beds, and she continues to do well with monitoring. She lives in Atlanta, continues to work, and is a former college swimmer and quite healthy at this point. So what do we know about spontaneous coronary artery dissection? Well, the prevalence is probably 0.1 to 4%, as you see here, depending on your demographics, location, and cath lab. In heart cath, approximately 1%, and acute coronary syndromes, up to 4%, again, depending on your patient population, the age of the patient. And we need to be particularly aware of this, have a very low threshold for considering SCAD, and young patients, women in their 40s to 50s, again, without traditional risk factors. The patients will often present with STEMI, but not always. So the presentation can be dramatic. A lot of what we know about SCAD is from case reports and case series, but we've learned a lot more about some of the SCAD registries in recent years, which I'll tell you more about. We think the recurrence rate, unfortunately, is not low, but it might be approximately 10% at 1 year and 20 to 30% at 5 years. So historically, we've understood and thought that pregnancy was the most common risk factor for SCAD. This is a case series from approximately 10 years ago. Sometimes we don't find what that risk factor is, and it's unknown, but pregnancy was the most common. But through case series like this, we've also learned that there are other risk factors, including exogenous hormones, connective tissue disease, isometric exercise, or trauma, for example. And lately we have learned that fibromuscular dysplasia is probably the most common underlying disorder that contributes to spontaneous coronary artery dissections. And we learned that from Jackie Saw approximately 8 years ago. She is an interventionalist from Vancouver who had a few SCAD patients in a row, and when she was taking a picture of the sheath after the intervention, she noticed that either the femoral artery or the radial artery had beating. And so that gave her the hypothesis that this was a underlying arteriopathy contributing to the SCAD. So she screened approximately 50 of these patients with CTAs of their body to look for underlying vasculopathy. And in fact, that is what she found, that up to 86% of these SCAD patients had fibromuscular dysplasia in one coronary bed. And so that was a very novel finding. There could be some referral bias here. So there are other reports now that show that FMD is at least present in 40% of these patients, but this is now the most common known risk factor for spontaneous coronary dissection. In fact, it is the same disease. It is FMD of the coronaries contributing to the SCAD in most cases. So how does FMD manifest in the coronary? So you've probably learned that FMD causes beating or a string of pearls appearance in affected vascular beds. Well, that's not the case in the coronary arteries. If you do present with chest pain, it's usually due to a dissection, like you see here in figure A, or figure C, like our patient, a type 2 SCAD, an intramural hematoma, which causes more of a tubular stenosis. But again, what we probably overlooked in the past, but we're now more aware of, is that FMD in the coronaries can cause subtle findings, such as smooth distal narrowing or marked tortuosity. And we really have to have a high index of suspicion for these patients, particularly younger women presenting with chest pain, to look for these subtle findings. So As far as angiography, it's important to give nitrates when you're looking for SCAD, and it can be really tricky, and it can be subtle, and it can be a branch vessel. So it does take a meticulous heart catheterization. There are 3 types of SCAD. Type 1 SCAD is your traditional double lumen sign or arterial wall stain, where you, in fact, can see the flap on angiogram. Type 2 SCAD, like I showed you before, is more of a diffuse smooth tubular stenosis caused by intramural hematoma, the most common. And type 3 is the most tricky because it's relatively focal and can mimic atherosclerosis. If there is diagnostic uncertainty, other coronary imaging techniques such as OCT or IVUS can be used, CTA of the coronaries. And again, after we diagnose the patient with SCAD, we typically do a CTA or MRA of brain to pelvis to look for an associated arteriopathy, the most common of which would be FMD. And here's an example on the left here of what a type 1 SCAD would look like. So you can see, based on these yellow arrows, that there is a double lumen or a flap in the mid LAD in this case, and probably some intramural hematoma distally. In this example, the patient was revascularized with a stent, and that had a good angiographic result, but you can still see some tapering distally. And fortunately, this SCAD did not propagate. But on a late follow-up, you have more recanalization. And again, the SCAD and intramural hematoma then distally has healed on its own. And again, when there's diagnostic uncertainty, OCT or IVUS could be used. You have to be very careful with your wire and catheter manipulation so you don't propagate the dissection. But you can usually appreciate an intimal tear or an intramural hematoma if there is one. So there are limited evidence for the management of SCAD. It's mostly anecdotal experience, expert consensus. However, there is a new AHA document from 2018 that with all of the experts commenting on the data that we do have, that's very organized and concise and helpful with management of these patients. At a minimum, we need to give aspirin and a beta blocker while the patient is in the hospital. There's probably not a significant benefit with heparin after the patient is diagnosed with their SCAD, so it can be stopped at that time. And there's no proven benefit of dual antiplatelet therapy. Revascularization is usually reserved for patients with high-risk lesions or hemodynamically unstable, such as cardiogenic shock. So you have to be careful with revascularization, because there's a high risk of complication, 36% technical failure. Imagine that's lower at our institution because this probably comes with experience, but you have to be careful for propagating the dissection, stent malapposition, causing stent fracture and residual stenosis. There's high risk of stent thrombosis or emergency CABG in these situations. So it really is reserved for the high risk patients. So who would you consider for revascularization? This diagram here is from our guidelines, that document that I mentioned. So on the left side of your algorithm, if the patient's hemodynamically stable and not high risk, conservative therapy. I also want to point out that, again, these patients can have recurrent propagation or recurrent SCAD up to 3 to 5 days after their initial event. So we really recommend keeping the patient in the hospital for up to 3 to 5 days. That's often frustrating for the team and the patient to be, quote, sitting around. But it's not uncommon at all to see this recurrence at 4 to 5 days. And if we discharge the patient too early, then they could come back with another MI. If the patient has high-risk lesions, you could consider CABG, but again, we lean towards conservative therapy as much as possible. Ongoing ischemia or hemodynamic instability, consider PCI and or urgent CABG. Here's another algorithm that was published in JACC that basically states similar recommendations that if you have diagnostic uncertainty, IVUS or OCC can be helpful. OCT, if you have confirmed SCAD that's stable, medical therapy. If the lesion is high risk, recurrent angina, cardiogenic shock, move to revascularization. So the patient then makes it to your clinic for hospital follow-up, and these are some of the things we focus on. Aspirin monotherapy is sufficient. Like I said, there aren't data for dual antiplatelet therapy. If they are on the dual antiplatelet therapy, we usually stop it at that time. There are data that beta blockers do improve symptoms and reduce your risk of recurrence in these patients. So beta blocker is the most important medicine for them to take, and aspirin and beta blocker should be a lifelong medication. Cardiac rehab is very important. We go for a lower target heart rate of closer to 50 to 70% early on. And as the patient improves their functional status and confidence, we can gradually increase that over that 70% predicted max heart rate. To avoid triggers in the future, avoiding things like heavy lifting, stimulants, hormones, and pregnancy is an important conversation to have with young women of childbearing age. We do a CTA or MRA of brain to pelvis on all of these patients to look for occult FMD, including aneurysms and dissections, which will be present, as you know now, in over 50% of these patients. And the recurrence rate is not low. It's up to 20 to 30% in 5 years. So a lot of education for these patients on recurrent symptoms, and mental health is also an important aspect of this. Next case. This is a 43-year-old woman who presents to clinic with severe hypertension and headaches. These are all real patients that were seen in the vascular medicine clinic, and some of these cases have either been published or presented at national meetings. So hopefully they're fairly interesting for you. Past medical history for this patient is significant for smoking only. Questionable history of aneurysm in the family, but details were unknown. In this case, the patient's blood pressure remains 160 despite 2 medications, and prior to that, she was healthy. So this is unusual. So she was referred to Emory Vascular Medicine for further evaluation. Her blood pressure in the office is now 211/93 despite adherence to these 2 medications. Renal duplex ultrasound was performed as part of a secondary hypertension workup, and it did show tortuous renal arteries with elevated velocities. And here's an example of what her renal duplex ultrasound looked like at the time. For those of you who read duplex ultrasound, that's great. For those of you who do not, as far as reference, this is your abdominal aorta here and your right renal artery branching off going to the right kidney. And what you can appreciate is that there is not laminar flow here. The aliasing or the mosaic color pattern of this artery suggests that there's turbulent flow. And you can also appreciate the turning or the tortuosity of this vessel, which is not normal, particularly for a young woman. This is more impressive as you get to the mid to distal vessel. Distally, you also see dilatation, suggestive of a possible aneurysm, and documented elevated velocities in the mid to distal right renal artery. So this patient did go to a renal artery angiogram because renal artery stenosis was identified as the likely cause of her resistant hypertension. So this is her right renal artery, and this shows impressive multifocal beating throughout the right renal artery, including proximal. And you do have the distal right renal artery aneurysm that we noted on the duplex ultrasound. So this is consistent with multifocal fibromuscular dysplasia, the string of beads appearance. It's important to point out that there is no validated way to quantify stenosis by duplex ultrasound or visually by any angiogram, including CTA, MRA, or invasive angiogram. The only way to prove a hemodynamically significant stenosis in FMD is a flow wire. So what we do is we take a ratio of the distal main renal artery pressure and compare that to the proximal or central aorta pressure. And if that ratio is less than 0.9, then it's abnormal, hemodynamically significant, and this patient will need an angioplasty. The left renal artery, you do appreciate some mild beating, but it is not hemodynamically by flow wire. Again, the ratio 0.92 is normal in this patient. So we proceeded to balloon angioplasty. Stenting typically is not needed for fibromuscular dysplasia, and it can injure the vessel and propagate a dissection. So balloon angioplasty was performed. In addition to getting a pressure gradient pre-procedure, you want to document a post-procedure gradient. So here's the post-procedure result, and you can still appreciate some of the beating or irregularity to the vessel wall, and that's okay. What you're really trying to do is stretch out the webs that are causing the stenosis within the vessel, and it's never going to look perfectly smooth. But unfortunately, after the initial balloon angioplasty, that pressure gradient was still, the ratio was still less than 0.9. So that was not a sufficient balloon angioplasty, and she required a repeat procedure, and that's okay. That's why we check a post-intervention gradient. And finally, after a subsequent balloon angioplasty, her gradient is now 0.98. That suggests a successful balloon angioplasty to the right main renal artery. And you could still appreciate the beating here, but hemodynamically, she should have adequate perfusion to her right kidney. So the clinical follow-up for this patient is that she had a dramatic reduction in her medication requirements. She was only on one medication that was titrated down. It did increase 1 year later, but her renal artery stenosis did not recur. Her headaches resolved, fortunately, and a follow-up renal duplex ultrasound demonstrated normal velocity. So what do we know about fibromuscular dysplasia? Well, it's non-atherosclerotic and non-inflammatory, so not traditional risk factors, and it is not an autoimmune disease, such as a vasculitis. The etiology and genetics are unknown. We still have a lot to learn about FMD. We're at the tip of the iceberg, and we've only known about FMD for the past 70 to 80 years. We have noted some genes recently where mutations have been associated with FMD. There's a gene called factor 1 with a PH that's associated with headaches and dissections. There's another gene mutation that was just identified recently in the literature of the COL5A1 gene, which is a variant of the classic Ehlers-Danlos gene. So there is a signal there, but we do not know the specific genetics of FMD. But we do know that it causes stenosis, occlusion, aneurysm, and dissection in affected vascular beds. The most common arteries involved are the renal and extracranial carotids in up to 2/3 of these patients. Due to the vague nature of the presenting symptoms, lack of awareness in both the patients and the providers about the diagnosis, there's a delay in presenting symptom to diagnosis of 4 to 9 years. So again, we have a lot of education to do as well. It's more common in women, up to 90%, and we don't know why that is. The average age is approximately 40. The most common symptoms are hypertension, over 50%, headache over 50%, and pulsatile tinnitus, 27%. We feel that the prevalence may be at least 1%, and we know that from autopsy data, renal transplant donor data, and renal denervation trials, where the prevalence is actually higher, up to 4 to 5% in angiograms. So how do we classify FMD? Well, there are two main types of FMD, multifocal and focal. The multifocal is what I just showed you. It's your string of beads appearance, and histologically, it is medial hyperplasia in the vessel wall, and it's 90% of the patients. So by far the most common type of fibromuscular dysplasia. The one that's a little more tricky is focal FMD, because it can mimic things like atherosclerosis, dissection, or vasospasm. It's more common in young patients, particularly boys for some reason, and histologically it's different than multifocal. It's the intima that's involved, but it's much more crescentic and smooth, and I'll show you an example of that. Here are examples of multifocal FMD, where you have the beating in the mid to distal affected vascular bed and the extracranial, internal carotid, and renal artery respectively, and you see this medial type involvement with these, quote, fibromuscular ridges, which lead to these alternating areas of stenosis and dilatation. In contrast, focal FMD, as you can see by angiogram, is tricky, it's discrete, and this could be misunderstood, like I said, for vasospasm or atherosclerosis, for example, but this is more seen in children. And the histology is completely different. You see the smooth intimal thickening. So most would agree that this is perhaps a completely different phenotype, but categorically it's multifocal versus focal FMD based on the guidelines. This is interesting. So you always want to consider the differential diagnosis of fibromuscular dysplasia, because all beating is not FMD. This angiogram of the femoral artery was sent to me by a former fellow last week, and what you can see here is an irregularity to the femoral artery here that looks like beating, but what you can appreciate, hopefully, is that this is very regular in appearance. And when you see something this regular, compared to multifocal FMD, you need to think about vasospasm. In this case, it's called standing waves, which is usually caused by a catheter and or wire, and this will resolve when you remove the wire or catheter and or give nitroglycerin, which it did in this case. So not all beating is FMD, and we see case reports once a year or so about standing waves that can mimic FMD, so be aware of that. So how effective is balloon angioplasty for FMD? Well, we know that the cure rate defined by coming off all blood pressure medicines is close to 50%, so that's great. And we have improvement in blood pressure in 80 to 90% of patients. And when we talk about restenosis, it's usually not the beating or the webs returning. It is usually an inadequate treatment in the initial balloon angioplasty, which again, you need to confirm that you had an adequate result by taking your pressure gradient post-procedure. Stent placement is usually not necessary because there is not as much incidence of restenosis as there is an atherosclerosis, and it could in fact injure the vessel because the FMD vessels are more fragile. So we don't want to trigger a dissection that's iatrogenic because of the stent. FMD is more durable when performed at a younger age, and this makes sense. The younger you are, the more likely you are to respond to the balloon angioplasty, and because as you're older, your blood pressure is more likely to be chronic and multifactorial and due to other causes in addition to the fibromuscular dysplasia. So the younger you are, the more likely you are to respond to the balloon angioplasty. We manage FMD with lifestyle modifications such as avoiding neck manipulation and heavy lifting, avoid tobacco use, hormones, and stimulants that could put stress on the vessels, antiplatelet monotherapy, antihypertensives if needed, and revascularization, which is rare, but when indicated, we would proceed. The CTA brain to pelvis is because of a study that showed, this is from our registry, that showed that in all comers, patients with fibromuscular dysplasia, an aneurysm or a dissection is present in avascular bed in up to 20 to 40% of these patients. So because of this, we recommend at least one-time screening with a CTA MRA brain to pelvis, and 3% of these patients will have SCAD in their lifetime. Okay, moving on to case 3. This is a 52-year-old woman who was referred to vascular medicine clinic for evaluation of her fibromuscular dysplasia. She was first diagnosed at age 29. And she's from the Midwest. She traveled to see us because we are an FMD center. She presented with a rupture, spontaneous rupture of her right iliac artery that required surgical repair. And she was fortunate to survive that rupture. At the time, they'd also discovered a left iliac artery aneurysm that also required surgical repair. And now she's presenting to us over approximately 20 years later to establish care. So at this point, she denies joint pain or hyperextensibility, joint dislocation or laxity. Hernia is nothing suggestive of a connective tissue disorder. Interestingly, her mother had a diagnosis of FMD and passed away from a brain aneurysm at age 52. And we think that at least 7% of FMD is genetic. So we do see this occasionally, but it's concerning that her mother had passed away of an aneurysm. This patient did have 2 uncomplicated vaginal deliveries. Fortunately, we actually have her records from 1996 from the aneurysm repair that was brought with the patient. And so we have a histologic confirmation of her fibromuscular dysplasia. And it's rare for us to see this now because most of these cases are not surgical. And again, I told you we use diagnostic criteria called multifocal or focal FMD. Before that, we used the criteria as medial or focal based on the histology and the layer, the artery that was involved. So to have a histologic diagnosis of FMD and have documentation of it is very unusual and helpful in this situation. On physical exam, it was overall benign. She did not have stigmata of connective tissue disease. She does have a bruit in her right groin, but no other significant abnormalities. So a CTA of the chest, abdomen, pelvis was done for surveillance and screening. And as you can see here, there are multiple beaded aneurysms and some alternating areas of stenosis in branch vessels of the aorta. So this is her celiac artery here, her SMA, and then her left iliac artery. And as you can see in her right iliac artery here, she does have some aneurysmal dilatation in a focal dissection as well. So she still has evidence of disease there. On her ultrasounds, she did have mildly elevated velocities and tortuosity in her renal and carotid arteries, which is not unusual for FMD, and her ABIs were normal. So this is not her carotid duplex, but this is an example of what it might have looked like. The vessel wall here in grayscale imaging is very irregular and tortuous, and you can almost appreciate the beading here in the mid to distal internal carotid artery. By color Doppler, you can appreciate the mosaic pattern. So the turbulent flow causing aliasing throughout the internal carotid. There are elevated velocities. And in this marked tortuosity, we call an S-curve, which is not diagnostic, but it's suggestive of FMD or another associated arteriopathy, particularly in a young patient. We see this in older patients, but when you're young and don't have risk factors, it's very unusual to have an S-curve in your carotid. So to confirm the diagnosis, again, you need to see multifocal beating, the beads on a string pattern. We do that usually with CTA or MRA. Here's an example of what it might have looked like. So you see the multifocal areas of stenosis and dilatation. In addition to diagnosing the FMD, we use this to diagnose incidental aneurysms, including intracranial aneurysms and any other findings we might come across, such as a dissection. And again, we cannot quantify stenosis angiographically without a flow wire. So these are data from the registry. The vascular manifestations of FMD for both the US and the European registries. And this shows you that, again, the most common vascular beds involved are the renal and the carotid arteries, respectively. We also see FMD involvement less commonly in the upper or lower extremities, the mesenteric arteries, coronaries, and from this registry, there's an aneurysm present in at least 20%, and there's a dissection present in at least 20%. And here the family history was 5%. And this chart points out that over 50% of patients will have two or more vascular beds involved. Multifocal being the most common again, and focal FMD is particularly rare in adults. So should genetic testing be performed? So we don't have a lot of data on this. And then, like I said, we do not have a specific gene identified. And this is from the international consensus statement that there's no justification for genetic testing, and there's not a specific test for FMD for the patient or a family member. So it's not recommended for most patients presenting with fibromuscular dysplasia. However, if there's suspicion for another connective tissue disorder that's in your differential diagnosis, you may proceed with genetic testing. So that's what we did in this patient. So what was unusual is this patient presented with aneurysmal rupture of the iliac arteries, and she had a family history of her mother who passed away from an aneurysm, which is quite unusual for FMD and suggestive of another more aggressive arteriopathy. So this patient was found to have a mutation of the COL3A1 gene, which is diagnostic for vascular Ehlers-Danlos. So the remarkable thing about this patient is she has a histologic diagnosis of FMD and a genetic diagnosis of vascular Ehlers-Danlos syndrome. So when we send a genetic panel on these patients, we're sending usually what's called a TAD panel, or genes that are associated with aneurysms and dissections. So looking for an addition of vascular Ehlers-Danlos, Lois Dietz, aneurysm, osteoarthritis syndrome, and Marfan's. So we send a panel that includes all these genes, and this patient, the COL3A1 gene was positive. So you can see that we were genuinely surprised. And again, as a reminder, the genetic testing is fairly low yield for fibromuscular dysplasia, but if there's a suggestion of something else going on, such as stigmata of connective tissue disease by history or physical, or some other presentation, like we saw in this patient with spontaneous aneurysm rupture, genetic testing is reasonable, and it's well within the differential diagnosis for a patient like this. So what do we know about vascular Ehlers-Danlos syndrome? Manifestations include arterial aneurysms and rupture, hyperextensible translucent skin, hypermobile joints, uterine rupture. The frequency is quite rare, 1 in 100,000, which is 4% of all Ehlers-Danlos patients, of which there's classic hypermobile and various types, some of which have genes, some of which do not. The maternal mortality is very high, and in pregnancy, it's up to 12%. This patient was lucky because, if you recall, she had 2 uneventful vaginal deliveries. So usually that's the case, that a patient is able to deliver vaginally without complication, but there's a high risk of mortality and a high risk of uterine rupture. So that is a particular concern with young females. And unfortunately, this patient did not have a complication during her pregnancies. 80% of patients will experience a major vascular event or rupture of an organ by age 40. The average lifespan is 48 years, and the COL3A1 gene confirms the diagnosis. Treatment, which included FMD treatment, but in addition for this patient, for her vascular Ehlers-Danlos, genetic counseling for both the patient and the family, physical therapy and occupational therapy to prevent other musculoskeletal and skin-related injuries, avoiding invasive procedures such as colonoscopy that can cause a visceral rupture, or an endovascular procedure that can contribute to an arterial rupture, which could occur in up to 50% of these patients. So avoiding all of these types of invasive procedures is important. A lot of education here for the patient and other physicians involved. High risk OB for family planning purposes, and or this discussion about prophylaxis and other aspects of childbearing. Surveillance of aneurysms over time. There's a high risk of recurrence of aneurysm and dissection. And as far as the data, how do we prevent these vascular events from occurring? There are data on a beta blocker called celiprolol that was reported a few years ago. I apologize, I didn't put the reference in there. But celiprolol did reduce vascular events by a significant amount, but in a study of only 25 patients, so has not been approved in the United States. Vitamin C is also occasionally given because it improves the collagen and wound healing in these patients, but the data are fairly limited in these patients for medical therapy of vascular Ehlers-Danlos. We can give beta blocker. We sometimes extrapolate Marfan's data and give the patient an angiotensin receptor blocker as well. Let me turn my light back on. My motion just went off. Okay. Case 4. This is a 30-year-old woman with no significant past medical history. She did have uncomplicated pregnancies. She's presenting with a diagnosis of difficult to control hypertension. She was started on multiple medications, including an ACE inhibitor. Unfortunately, her creatinine started to increase. It was normal, and now it's 1.5. And on review of systems, she reported myalgias, arthralgias, arm numbness, fatigue, dizziness, and chest pain. So she was admitted to an outside hospital. She's from rural Tennessee. She presented with a hypertensive crisis despite adherence to her medications. Her creatinine at the time was 9, and she was started on hemodialysis. For the record, she had a normal renal ultrasound and acute tubular injury without intrinsic renal disease on her biopsy. Rheumatology evidently saw her and ruled out autoimmune disease, but there was concern given her myalgias and arthralgias. So the interesting aspect of this story is that, again, she was in rural Tennessee, and she was in line at a gas station to pay and was discussing her hemodialysis with a friend, and the person behind her overheard the conversation and recognized that that was unusual and abnormal, concerning, and recommend that she go to Emory for an evaluation, which she did. So she presented to Dr. Navarrette's office and was admitted immediately for an expedited workup of her renal dysfunction. When we saw her on exam, she did have a systolic murmur, carotid bruise, and a diminished left radial pulse. She also had complaint of a floater in her right eye, and was found to have severe hypertensive retinopathy. And again, this is a very young woman who was previously healthy 1 year prior to this presentation. Her labs showed significant abnormalities. She was anemic, thrombocytopenic, bilirubin was mildly elevated, ANA was mildly positive, and her CRP was elevated, which is, again, kind of somewhat difficult to interpret given that she's had symptoms for over a year at this point. The MRA of her renal arteries was performed first because of her resistant hypertension and renal dysfunction. So on this image, you can see diminished flow to the right kidney from the right renal artery here. And on the left side, you do not see, confidently, you do not see flow going to the left kidney on this image. So concern for severe renal artery stenosis and or occlusion bilaterally. So at this point, the differential diagnosis for her renal artery stenosis is listed here. Atherosclerosis is the most common cause of renal artery stenosis. That would be somewhat unusual for this patient who's young and doesn't have traditional risk factors. FMD would be the second most common cause of renal artery stenosis. because it does involve a younger patient population, and she is a woman. But she did have some other systemic symptoms that wanted you to consider vasculitis. So polyarteritis nodosa, a medium vessel vasculitis, Takayasu, a large vessel vasculitis, or radiation, for example, and also a more third differential diagnosis, including neurofibromatosis type 1, coarctation of the aorta, dissection, or segmental arterial medialysis, or SAM. SAM is similar to FMD in that it is non-atherosclerotic and non-inflammatory. In contrast to FMD, it's more rare, and it typically presents with visceral artery aneurysms at ruptures, and it's more common in middle-aged men. The diagnosis is by biopsy, so this is even more rare than FMD. I've seen 2 patients with this so far. It's usually a diagnosis of exclusion. So her renal artery angiogram was performed next because there was concern for significant renal artery stenosis. She does not have beating on her renal arteries, but she has sequential areas of stenosis that was very severely stenosed, both the right and left renal arteries. She did have a successful balloon angioplasty to the right renal artery by interventional radiology. And on the left, you can really appreciate the subtotal occlusion in the left main renal artery that was difficult to revascularize, but they were successful with stent dilatation here. So she did have a bilateral renal artery revascularization procedure. Again, we were concerned about her systemic symptoms. If you recall, she had a bruit on exam and a diminished left radial pulse, so a carotid duplex ultrasound was performed. This is her common right and left common carotid arteries, respectively, coming right off the aortic arch, and this is marked thickening of the vessel wall that's very smooth and tapering down into the internal carotid artery. This is not atherosclerotic, but more concerning for inflammation or autoimmune disease such as a vasculitis. And this is pretty classic. If you were to see this duplex ultrasound image in cross-section, it would look like a halo or a donut, but this is marked thickening of the vessel wall, presumably due to a vasculitis. So to confirm that, we performed a PET FDG, and it did show active areas of inflammation in the bilateral internal carotid arteries that we noted with the carotid duplex ultrasound. We did not see this in the renal arteries or anywhere else, but again, she's had this inflammation for over a year. So the thought was that her renal arteries were, quote, burnt out at this point, and her active inflammation was down in the carotids and subclavians. So the diagnosis for this patient was Takayasu's arteritis. So it's a large vessel vasculitis, primarily affecting the aorta and its branch vessels. This patient met most of the criteria for Takayasu. She was young. She was younger than age 40. She was Caucasian, which is less common. It's more common in Asia. So the incidence in the States is approximately 2 in 1 million, so quite rare. You need to meet at least 3 of the 6 criteria. And again, she met almost all of these with her age, upper extremity claudication, diminished pulse, blood pressure differential, bruit, and arteriogram abnormality. She met all these criteria for Takayasu's arteritis. And this is a total win, a total save for this patient. She had normalization of her renal function. She did not require dialysis after the renal artery revascularization. She was treated with steroids, which were gradually weaned, and she's currently stable on labetalol. So just remarkable that a patient prior to seeing us was on dialysis and now has an excellent quality of life. And she's a mother of 3 or 4 kids up in Tennessee, and very stable on her antihypertensive monotherapy. So some conclusions here: spontaneous coronary artery dissection should be considered in chest pain patients without traditional risk factors. Fibromuscular dysplasia may cause hypertension, headaches, and pulse-style tinnitus, particularly in young women. So we need to have a low threshold for looking for this, including this in the differential, particularly in young patients without risk factors, and have a high index of suspicion. So when there is a newer suspected diagnosis of SCAD or FMD, I recommend performing the CTA or MRA of brain to pelvis to look for FMD, aneurysm, or dissection, but always consider alternative diagnoses in your differentials, such as vasculitis, vasospasm, and other connective tissue diseases. and just to update you on our research. So like Pooja said, we are involved in the national registries for fibromuscular dysplasia and for spontaneous coronary artery dissections. We've been involved in the FMD registry for over 5 years now. There's 16 or 17 centers, as you can see. We're consistently one of the highest enrolling centers for FMD, and 1 or 2 years ago, we were the highest enrolling center in the country, seeing approximately 30 to 40 new patients annually. And a lot of the science that you're seeing, the consensus statements and the research are coming from the US Registry for FMD. We were fortunate to put together a multidisciplinary team that can treat all aspects of our FMD patients, from cardiology to vascular surgery, nephrology, neurology, etc., vascular genetics, and you could see all those experts here all work very well and communicate together. And it's a real benefit to the patient. Many of them are referred from out of state, and it benefit very greatly from seeing all the specialists when they come visit us. We also have involvement from cardiology and women's health with Dr. Lundberg and Pooja. As far as the SCAD registry, that's relatively new. Wanted to tell you, for the FMD registry, we have close to 3,000 patients now. So that's a fairly robust registry at this point. For the SCAD registry, it's fairly new. It's been going on about a year at this point, and we have close to 400 patients enrolled nationally. You can see the centers listed here. Emory currently is the 6th highest enrolling center. And there are no publications yet from the SCAD registry, but you should expect to see some soon. As soon as we get closer to 400, 500 patients, you'll start to see publications from the SCAD registry. So we're fortunate to be a part of that. You can see our spontaneous coronary dissection team here: Rebecca Laleko, Gina Lundberg, Pooja Mehta, and myself are happy to help you with your patients, whether they have SCAD or FMD, or enroll them in the registries for you. And I also wanted to thank you, the audience, and thank our other vascular medicine experts here at Emory, Dr. Laleko, Dr. Harzand, and our new nurse practitioner, Anna Foreman. Thank you so much for your time, and I hope that was interesting for you and gave you a good overview of the patients we're seeing in vascular medicine clinic, and a flavor of the breadth of pathology that we're seeing in clinic. So thank you again for your time.
Thank you so much, Brian. That was outstanding and a really great review. I really like the case-based approach. We'll take questions. And while I'm waiting for the audience to type in their questions in the chat box, I'll start off with a question. So your second case, hypertension headache is just so common. So at what point do you start, if somebody has blood pressure that's resistant hypertension, you start with a renal ultrasound, and let's say that's okay. Do you keep pursuing a further scanning for some of these vascular problems?
Very good question. And we encounter this a lot. It's not uncommon, particularly in vascular clinic. But it all goes back to that high index of suspicion. When it's unusual, in this case, usually a young woman presenting with resistant hypertension, you have to look for those secondary causes. Sometimes it's not renal artery stenosis. You have to consider the other things as well, and do a full secondary hypertension workup. However, if there's any signal about FMD or another related arteriopathy, if you hear a bruit, right, abdominal or a carotid bruit, if they have frequent headaches or migraines, which are present in over 50%, again, that's common, so that's why it's tricky. Pulsatile tinnitus is also a very helpful symptom to ask about. It's not diagnostic, but 27% of FMD patients will have pulsatile tinnitus. If you get any signal like that and don't have any other diagnosis for their resistant hypertension, you start with the renal duplex ultrasound. But we have a case at least once a year where we're sure the patient has FMD or something, and we have to keep looking and not accept a normal renal duplex ultrasound and get a CTA, for example, a CTA or an MRA. In fact, we have about once a year a CTA that's normal, where we're so confident that there's renal artery stenosis that we go to invasive angiogram. So if there's diagnostic uncertainty, you keep looking, and we The person who's had the most experience with this is one of our colleagues, Alexis Cutchins, who's very persistent. She sees a lot of young women and takes good care of them. But once a year, she'll find a patient where the CTA looks normal, and we move to invasive angiogram and we find the FMD. And I presented that at a national meeting as a topic last year called Pitfalls of FMD Imaging. So the sensitivity is not 100% for CTA MRA. So that's a very good question. You have to have that index of suspicion.
Great. So we have Niazi Khusro. Did you want to comment, Dr. Khusro?
Yeah, Brian, a great presentation, very nicely presented in 45 minutes. We have treated a few Takayasus and giant cell arteritis patients who have had significant subclavian artery disease, and many times they present, by the time they present to us, it's already occluded 100% because physicians forget to check the blood pressure in the upper extremities to see for disparity. And the reason we have treated them percutaneously rather than sending them surgically is because this is an inflammatory disease, and the surgeons are reluctant. They are afraid their grafts will close down. However, when the stents develop restenosis, we have treated them drug-coated balloon with excellent results. Do you have any data that drug-coated balloons role in endovascular treatment of these patients?
I do not, and I don't know that there are any data for drug-eluting balloons for treatment of any type of vasculitis, and that's a great question on the method or approach of revascularization for residual stenosis due to vasculitis. For the audience, you do want to wait until the patient is out of the inflammation phase of their vasculitis. So if you revascularize too soon, then the inflammation is persistent and the stenosis or vascular damage can return. So that's what Dr. Niazi's saying, is that you wait until you're in the burnout phase of the vasculitis and you're left with residual stenosis. And if it's lifestyle limiting or symptomatic, you consider revascularization. And it sounds like he's done a good job with that on a few select cases. We try to avoid it if possible. And oftentimes it's more of a quality of life issue, is there upper extremity claudication or steel or something like that going on? So it sounds like, Dr. Niazi, you have as much experience with that as anybody, but I don't know of any data for it.
Thanks, Brian.
Thank you.
I'll ask another question related to SCAD. So a lot of these patients, after they have their SCAD event, they tend to have a lot of chest pain. And, the question is, I wanted to kind of get your thoughts about the possibility of microvascular dysfunction in this population. What is known, and is anybody looking into that in the iSCAD registry?
You and I have talked about this, Dr. Mehta, and you and I were actually trying to collaborate on a study for microvascular disease in patients with SCAD. So that's an interesting theory. We know that the suspicion is that you and I have discussed is that their coronary flow reserve may be low and suggestive of some microvascular disease in these patients. And I don't know that we've proven that, but that's a very interesting question. But clinically, absolutely, that is what we see after a SCAD event. Some of it's due to anxiety, and that's understandable. Some of that is due to residual ischemia from hemodynamically significant stenosis. But clearly, we see patients with angina or chest pain-like syndromes after their SCAD event. Most of it can be treated with a vasodilator like a calcium channel blocker or a nitrate, and it's presumably due to vasospasm or microvascular disease. I personally tend to avoid more invasive testing just to avoid the risk of dissection and other vascular injury, but it's not uncommon to have to treat a SCAD patient with some type of vasodilator after their event, even if they don't appear to have a hemodynamically significant stenosis. Sometimes it occurs with their headaches. Other times it occurs with the menstrual cycle or catamenial chest pain. So it can be treated periodically or by episode. But that's where the medical therapy, psychiatric evaluation can help as well, because there's real anxiety associated with it, and cardiac rehab.
Okay, great. I'm going to ask Dr. Samady to comment, and he has a question.
Bryan, that was really excellent as well from my perspective. With regard to the Takayasu's, you mentioned that of the criteria that you laid out, you have to have 2 or 3 of them positive. And it's interesting that the angiographic appearance appears to be only one of a number of criteria that would result in a diagnosis. Is it not really important to, I would have thought the angiographic or imaging characteristics of that diagnosis would be really important to distinguish it from other types of arteritis. So that's just a question, but just a brief comment about the microvasculature and SCAD. I agree with you that you probably do not want to instrument these vessels invasively, certainly, but non-invasively, you could examine the relationship as you and Pooja are proposing. I also just want everyone to know that we do have a pretty active program in the cath lab, and we recently published our experience, and actually last week in Sky. So we are open to evaluating any of your patients in the cath lab that you would like to be evaluated for microvascular disease.
And thanks, Habib, you actually helped me with a patient last week and really helped his quality of life for his vasospasm. And to touching on the comment about the clinical criteria for Takayasu, those criteria that the rheumatologists like to emphasize is those criteria are developed primarily for research, those qualifiers, and they're not necessarily the most reliable clinical indicators for the diagnosis of a vasculitis such as Takayasu. So you're absolutely right that a person can have a large or medium vessel vasculitis and it could be Takayasu's and not meet most of those criteria. And you should put more emphasis on the arteries that are involved. And like you said, the invasive and the non-invasive imaging that is more suggestive, in this case of the Takayasu's, to differentiate it from others. Absolutely. So it is interesting that it's only one of the criteria, but the rheumatologist always emphasize that the criteria, don't get too hung up on the criteria because most of that is for categorization for research purposes.
Bryan, any comments about in terms of treatment for Takayasu's? Are the rheumatologists recommending biologics or sort of anti-inflammatory meds in addition to what we do in cardiology?
Yes, good question. And all of that is off-label. Last I heard, for the treatment of Takayasu specifically, or these large to medium vessel vasculitis entities. So prednisone, the patients usually started on steroid therapy until they have resolution of their inflammation, or at least reduced or stable levels of inflammation. And they typically measure that by the patient's symptoms and a combination of biomarkers, sed rate CRP, as well as imaging findings to assess the activity of the patient's vasculitis. And the goal obviously is to be on the smallest dose of steroid as possible. So weaning the steroid over time to monitor closely for recurrence or a flare of the vasculitis. But what they're doing off-label is transitioning to a non-steroid immunosuppressant. So like CellCept, for example, or a TNF-alpha inhibitor. Those are all tried, and there are data and evidence that suggests that it helps. And this patient's on a non-steroidal anti-inflammatory as well. But it's off-label at this point.
Okay, great. Does anybody else have any questions or comments? Okay, then I'll close and we will resume next week. See you then.
The preceding program is copyrighted by Emory University.